If you want to grab a coffee, you can go and do it quickly and bring it here. This session is dedicated to nephrology, and my name is Muna Rukhemi. I am consultant nephrologist and physician, and my colleague who is chairing this session with me, Dr. Abdullah Marzouki, he is internal medicine specialist at Rahba Hospital. We will have different subjects, hopefully of interest to the internal physician. I'll start by introducing the first speaker, Dr. Hormaz Dastoor. He's a colleague of me for a long time, and he's a consultant physician and nephrologist at Saha Care, Kidney Care, which is a new system created by Steve, who will be a speaker at the end of this session. Dr. Dastoor is a specialist. In fact, he's in electrolyte disturbance. So he will cover the topic of hyponatremia, which is commonly faced by the internal physician also. So Dastoor, you can start.
Okay. Thank you, Dr. Mona. Let me just start by saying that 20 minutes for hyponatremia is a challenge, right? Because nephrologists take a lifetime to understand hyponatremia. So to explain hyponatremia in 20 minutes is a big challenge. So if you don't get anything out of this lecture, don't worry. If you get something, be grateful, okay? The objectives of this lecture are mainly to understand a bit about water control mechanisms, complications of hyponatremia, do a few numbers behind hyponatremia, maybe if we have time, do 1 or 2 cases. So this is hyponatremia from up to date. So as you can see, it's nearly impossible when you have a patient to try and analyze this. But interestingly, on one of my trips to India, I found a slide over here, and it says that to break the rules, you must first master them. So if you don't know the basics of hyponatremia and how the body responds to hyponatremia, then I think you will have a tough time treating hyponatremia. So today I want to focus just on the basics and the physiology of what happens in hyponatremia, and then maybe next year we can discuss the treatment of hyponatremia. So hyponatremia, you can classify it into mild, moderate, and severe based upon the numbers, 130, 134, 121, 129, or less than 120. Or you can also classify it based upon your symptoms. So if you have mild symptoms like headache, nausea, vomiting, or more severe symptoms like seizures, respiratory depression, coma. So this is an emergency, this is an urgency, and this is just a mild hyponatremia. And you should know that hyponatremia is not a salt problem, right? It's mainly a water problem. So when you hear somebody say hyponatremia, the first thing you need to realize that you have a lot of water in the system. It's got nothing, I would say in 95% of the cases, it's got nothing to do with salt, but it's basically a lot of water in the system. So what is hyponatremia? If you take 140 millimoles of sodium and you add 1 liter of water, then you get your normal sodium concentration of 140 millimoles per liter. So that's the normal labs. Now, if you have a pathophysiological state like SIADH, so as the name suggests, ADH, you have a water problem and you are retaining water. So the amount of sodium is the same. You still have 140, 140, but the amount of water has gone up. So the ratio of sodium to water, which was 140 over 1, now becomes 140 over 1.1 liter, and the sodium goes down to 128, okay? So just to summarize, there's no problem in the sodium. You still have the same total amount of sodium, but your water, total body water has increased, let's say by 1 liter, and hence the plasma sodium, which is a ratio of sodium to water, has gone down. So this is the majority of hyponatremias. I would say in 95% of hyponatremia, from whatever the cause, SIADH or heart failure, this is what is happening in the system. And the treatment of this hyponatremia is just to get rid of this extra water, either by fluid restriction or diuretics, and to bring the sodium level up again. In about 3 to 5% of the cases, you may have what is called hypovolemic hyponatremia, where both the sodium go up and the water amount goes up. So in this example, you can see that sodium has gone up by about 15% and water has gone up by 20%. So even though your total body sodium has increased, you are still not hypernatremic. In fact, you're paradoxically hyponatremic because your water amount has gone up more than your sodium amount, okay? So basically, just try and remember that when you have hyponatremia, it is not a sodium problem, it is a water problem. I hope that's clear. Okay, so why is hyponatremia important? Because hyponatremia is the most common electrolyte abnormality in the hospital. So as an internist, you will see a lot of patients with hyponatremia. And about 5% of the patients will have a severe hyponatremia where the sodium is less than 125. It's also important to note that hyponatremia is a normal finding in pregnancy because of the hormonal changes, you retain water. So if you see a normal sodium in pregnancy, that is considered to be abnormal, you know. It indicates usually free water losses such as volume depletion or preeclampsia. So remember that in normal pregnancy, when you have hyponatremia, that is kind of like a danger sign. What are the complications of hyponatremia? Remember when I showed you the classification, there is mild, moderate, and severe. You can also classify hyponatremia as acute or chronic. Acute hyponatremia occurs over less than 48 hours. Chronic hyponatremia occurs over more than 48 hours. Essentially, the symptoms are similar: dizziness, ataxia, confusion. But acute hyponatremia can develop seizures and increase your mortality. Chronic hyponatremia, there's less chance to develop seizures, but we've seen that patients who have chronic hyponatremia also tend to have increased mortality. And it's also important to note hyponatremia because most of medical lawsuits in the US are related, quite a high number are related to hyponatremia. And you can see the payments for these lawsuits, they go into millions. So it's quite important for both internists and nephrologists to recognize hyponatremia and treat it appropriately. So hyponatremia is dangerous for the CNS, but also you need to realize that treatment of hyponatremia can also have CNS effects. So if you have acute hyponatremia, where you have an acute swelling in the brain cells, that condition is called hyponatremic encephalopathy. On the opposite spectrum, if you correct the hyponatremia rapidly, you get what is called osmotic demyelination syndrome. So you're kind of like stuck both ways, right? If you don't recognize the hyponatremia, your patients get a hyponatremic encephalopathy. If you're too enthusiastic to treat hyponatremia, you may end up with another complication. And all nephrologists, including our next speaker, knows, Dr. Stephen Holt, how many times I have got into complications with DOH, with hyponatremia, right? Next, okay. So just to show you again, this is a normal brain size. When you get hyponatremia, even a 5% change in your sodium level, if it goes down, you can have cerebral edema and herniation. So that's an important complication of hyponatremia. So let me show you this slide. So you have a normal brain cell, and in the normal brain cell, you have potassium, phosphorus, and you have organic solutes. They maintain the size of the cell. When you have a hyponatremia, the cells start to swell up and compensation starts immediately within minutes. So within minutes, potassium and phosphorus, they go from inside to outside the cell to try and shrink the cell again. And then there is a chronic compensation within 2 to 3 days where the organic proteins and solutes like inositol, arginine, they also leave the cells and they try to reduce the size of the cells and to reduce overall brain swelling. So chronic hyponatremia is more than 48 hours, but you can see that still there is some degree of brain swelling compared to a normal cell. What is important to note that acute hyponatremia, when it develops over less than 48 hours, yes, the acute hyponatremia causes brain swelling, but at the same time, before these changes have occurred, if you reverse the hyponatremia, you can reverse it very quickly without causing harmful effects. On the other hand, if you have a chronic hyponatremia and you reverse it rapidly, you may cause decrease in size of the cells, causing an osmotic demyelination syndrome. So the take-home message is acute hyponatremia is dangerous, more dangerous than chronic hyponatremia, but treatment of acute hyponatremia, if corrected rapidly, is not dangerous. But treatment of chronic hyponatremia, if corrected rapidly, is very dangerous. Yeah, so this is where most nephrologists and internists get into trouble. Acute hyponatremia, you can see patients who have run a marathon, or they've gone to a rave party, taking some drug, ecstasy. They come in with acute hyponatremia. You can just bolus them with 3% saline, and you won't have any problems. Chronic hyponatremia, usually you'll see like these old ladies sitting at home, a little malnourished, they're drinking a lot of water, not eating a lot of meat. If you correct them rapidly, you're more likely to get osmotic demyelination syndrome. Next. And this is an example. This is a true case where a patient was corrected rapidly in our hospital, Rahba Hospital. Luckily, not by me, fortunately. And he got paraplegia after approximately 2 weeks. And when a CT scan was done, you can see over here these areas of central pontine myelinolysis. And unfortunately, the patient was paraplegic for the rest of his life. Chronic hyponatremia can sometimes be very subtle. You'll see a lot of old ladies. They complain of lethargy and headaches and inappropriate gait. So if you look at the gait pattern, they are not able to walk in a straight line. They walk haphazard. And it's also one of the most common unrecognized causes of falls in the elderly. So with chronic hyponatremia, not only do you get unsteady gait and falls, they also add risk of osteoporosis. So what's the normal response to hyponatremia? So when you have, let me just skip ahead here. So when you have hyponatremia, there are some nuclei in the hypothalamus and the pituitary called the supraoptic and paraventricular nuclei. They sense that you have hyponatremia and they suppress your ADH release. So the reason for ADH suppression is that because hyponatremia is a state where you have excess water, when you suppress the ADH, you try to get rid of that water and then bring your sodium level up. And ADH suppression can be measured in 2 ways. Number one is you can send off a lab test to France or the US, and you can wait for 2 weeks for the ADH level to come back, or you can measure it indirectly by checking the urine osmolarity or the specific gravity. So ADH suppression is usually reflected in a urine osmolarity less than 100 milliosmoles. So if somebody with hyponatremia has suppressed ADH, you can measure it with lowered urine osmolarity, and that is a normal response. On the other hand, if you have somebody with hyponatremia and their ADH is not suppressed, The urine osmolarity will be more than 100, and that is an abnormal response. So my suggestion for you is whenever you see a hyponatremic patient, try and get a urine osmolarity. If the urine osmolarity is less than 100, you know that that is a normal response, and the kidneys will compensate by themselves and correct the hyponatremia. But if the urine osmolarity is more than 100, then you know that ADH is being produced despite the fact that they are hyponatremic, probably from SIADH or heart failure, etc. And that is an abnormal response, and you have to intervene in this condition. This is an old slide. I sometimes show it. This is from 1960. You can see that on this slide, if a patient becomes hyponatremic, if his sodium goes up, there is an ADH release. But if the patient becomes hyponatremic, you can see the sodium going down. There is an immediate suppression in ADH levels, right? So hyponatremic patients should have ADH suppression measured by urine osmolarity less than 100. Another stimulus for Adh stimulation is volume. Whenever you have a volume decrease, there is an Adh stimulation. The difference here is volume is not very strong stimulus for ADH release. You need to have at least 10% decrease in your volume to have an ADH release, yeah? But osmolarity or sodiums are very sensitive to ADH. So whenever you have even a slight increase or decrease in sodium level, you will have a sudden increase in ADH or a decrease in ADH secretions. So if you look at the classification, this is a simple classification, right? Not like the up-to-date, yeah? So when you have somebody with true hyponatremia, I think you should measure their ADH level. If the urine osmolarity is less than 100, that is kind of a normal response to hyponatremia. It happens in primary polydipsia or somebody who's auto-correcting. But if somebody has hyponatremia and the urine osmolarity is more than 100, then that is an abnormal response. And there are different reasons. And most of us know that we classify them as isovolimic hyper or hypovolemic hyponatremia. An example of isovolimic hyponatremia is SIADH, hypovolemic is CHF and nephrotic syndromes. Hypovolemic is like GI losses, etc. So quickly, let me go over here. I only have 3 minutes. Sorry. What is urine volume? How much urine are you supposed to make per day? Urine volume is basically the amount of osmoles in the urine divided by urine osmolarity. If you eat a high protein diet or a normal protein diet, then your osmoles per day is around 600 osmoles, and the maximum urine osmolarity is around 1200. So the minimum amount of urine you must pass a day, even if you don't drink any fluid, even if today you stop drinking water, but you just have a steak or something, you will still pass urine because these osmoles will force a diuresis in you, and you will, at a minimum, secrete around half a liter of urine. And that's basically where the definition of oliguria came, right? Oliguria is defined as less than 500 milliliters per day, because even if you don't drink any fluids, the osmotic load will force you to excrete some urine. Let me just go through this because, as I said, it's impossible in 20 minutes. So let's try and review this case of hyponatremia. So when I was in Rahba Hospital, we had a gentleman from Saudi Arabia, and he presented to us with plasma sodium of 113, and he had some symptoms such as headache and lethargy. So how would you approach this patient? I told you the first thing you have to do is to measure the urine osmolarity. The normal response with a sodium of 113 would be a suppression in your ADH. And you can measure that by checking the urine osmolarity. It should be less than 100. But this gentleman, his urine osmolarity is more than 100. It is 580. So instinctively, you should know that there is Adh stimulation in the system. So this Adh stimulation is an abnormal response, okay? And since the patient is euvolemic, he fits into the category of SIADH because he's hypotonic euvolemic hyponatremia. The causes of SIADH are multifactorial. You can have drugs or pulmonary problems. In this case, it was his medication. How do you treat the hyponatremia? Because he's symptomatic, you have to give him hypertonic saline. You give them 3% saline based on this formula. Unfortunately, I don't have time, but if you email me, I'll explain to you the formula. But what is more important is that, can you go forward? The long-term management of any hyponatremia is to increase the urine volume. And the main way to increase the urine volume is by recognizing the urine volume formula, which is osmoles in diet by urine osmolarity. If you can increase the osmoles in the diet, you can increase your urine volume. If you can decrease your urine osmolarity, you can increase your urine volume. So how do you increase the osmoles in the diet? You give the patients a high protein diet, or in some countries you have urea, or you can decrease the urine osmolarity. You can do that by giving them some medications like lithium, minocycline, or furosemide. So if you do these two things, you can increase your free water excretion and the plasma sodium will automatically come up. I don't have much more time, so I think I'll have to stop over here. But I hope you understood and got an idea a little bit about hyponatremia, how to diagnose what is a normal response, what is an abnormal response, what are the complications of acute hyponatremia, what are the complications of treating hyponatremia quickly, and how to work up a patient with hyponatremia based upon the urine osmolarity. Thank you.
Dastoor, for this excellent review and simplification of the matter. We'll leave the question to the end of all four talks. I'll leave the microphone now to my colleague.
Yeah,
President
for